let's turn our attention to some of the concerns we might have for the woman who's interested in getting pregnant or the pregnant woman and the mother-to-be. One of the reasons I want to talk about nutrition for pregnancy is that it's such a critical time in gestation when we have this opportunity to eat really well and do good things for our body, and in that process we're going to nourish this fetus, this whole nother human that we're growing. One of the things you really want to appreciate around nutrition during pregnancy is that the nutritional demands during pregnancy are exponential. They are so extraordinary, and it's micronutrients, it's calories, and then it's all of those macronutrients we talked about. So making sure that you're getting enough of the right kind of fats in your diet, fiber, all of these other things that we've talked about all semester. So I want to start with one vocabulary word that I think is pretty important for us to understand, and it really sets the stage for some of the nutrition problems that we can see sometimes. So this is this term called critical periods. And this is a time during that gestational cycle when organs or different kinds of tissues are forming. Now, the reason that it's critical is that you have to have the right supply of nutrients during this time period, or sometimes there can be some abnormality in the formation and growth of those tissues. So when we look at critical periods, we can see different kinds of things that can go wrong, and especially around the nervous system. We're going to talk about neural tube defects in a few minutes and our opportunity to prevent that with folate. We'll also think about dental health. Here we're thinking maybe about calcium and vitamin D and some of those bone building minerals. And then we want to also take a moment to just think about the long-term health of that child as he or she is growing. So you have to think about the immune system. Okay? Now, if there's some kind of a nutrition insult or deprivation, and we use that word insult very purposely, because if you think about a fetus being deprived of certain nutrients, but then also sometimes having extra nutrients that aren't required, it is considered an assault on the tissues that are developing. These are irreversible. So if we see some kind of an abnormality, like a neural tube defect, we can certainly correct that with surgical intervention, but the child isn't going to be able to outgrow that, which is really what I want you to be thinking about. So one of the concerns we have right now with gestation and pregnancy is this incredibly high rate of type 2 diabetes. There are small epigenetic changes that are occurring in the fetal tissue. So we have concerns about how these changes are going to manifest long term. So I'll talk a little bit about that later. So one of the things you often hear women say, they find out they're pregnant and they say, I'm eating for two. Well, we want to kind of dispel that myth, because we really don't want women to be eating for two, ever, but there is increased nutritional needs for the pregnant woman. Now, during the first trimester, and if you're not familiar with that trimester system, it's 3-month periods of time, and so there are 3 of those because it's a 9-month gestation for humans. So during the first trimester, first 3 months, no additional energy. Okay, so think about the women you know, and they find out they're pregnant maybe at a month and a half, and they say, oh, I'm ready to have an extra meal or something. We need to get away from that. Even in the second trimester, you only get an additional 340 calories a day, or 350, and this is going to vary, of course, depending on the preconception weight of the mother, and then also if she has, twins or triplets or whatever the situation is there, or if there's any kind of disease state. And then during the third trimester, that last stage of pregnancy, about 450 calories. Okay, there are some different ways to do this, of course, and most women will just eat more food. Some will reduce their activity level, and I really want to get people away from that. Maybe shifting activity. So if you were, a hardcore runner, you may need to ease away from that a little bit, because it's going to become a little bit uncomfortable as the woman becomes larger to be able to be engaged in that. But again, pregnancy is not an illness. We have this mindset that when a woman is pregnant that she's somehow to be pampered. And yes, that's true, we should buy her gifts and shower her with all kinds of lovely things, but it doesn't mean that she can't be active and really vital. The other thing you want to keep in mind is that some women will actually shift their fat storage mechanism just a little bit, and that can kind of result in some extra energy. Okay, now this doesn't mean Hershey bars or ice cream or Fritos or any of those kinds of things. It means that we want that woman to still have a very, very responsible diet and have food coming from, here I've listed 5 food groups. It depends on what nutritionist you ask. There are as many as 8 food groups, depending on how we kind of parse our diet. I mentioned preconception weight status. We want women to be really at a healthy body weight when they get pregnant. Now this is kind of tricky sometimes, especially if you consider that 1/3 of our population is at an appropriate body weight or slightly underweight, and then 1/3 is overweight and 1/3 is obese. So these numbers really are consistent for all different age groups, and we're seeing more and more younger people that are really quite heavy. And it can be very difficult to reach that healthy body weight before a woman gets pregnant. And again, consider that 50% of pregnancies are unplanned. So we want people to live a really healthy life. This is even more of an impetus to do that. All right. Now, even a woman who is considered overweight or obese at the time of conception needs to gain weight. Okay, this is not a time to diet or try to lose weight or anything like that. One of the things that happens when women fail to gain weight is that they actually increase the risk that they have a low birth weight infant. So we want to make sure that she is gaining an appropriate amount of weight. And we'll talk about how much that is. It's not 50, 60, 70 pounds that sometimes you see women gaining. That's actually a failure in the nutritionist's eyes. Okay? And when we look at birth weight, it's incredibly critical that that infant is born at an appropriate birth weight, because it's the single most important factor regarding that infant's long-term health. Even short-term health can be compromised when that infant is less than 5.5 pounds. Now, in your book, they have this wonderful list of different kinds of nutritional factors or even lifestyle factors that will put a woman at risk for a low birth weight infant or a poor pregnancy outcome. And some of these should be, probably fairly obvious. So smoking cigarettes and being addicted to alcohol or illicit drugs, or even taking medications that are prescribed by a physician, can be very dangerous. So we need to check out that. We have concerns for people on special diet plans, whether it's lactose intolerance, whether they're a vegan, vegetarian, and it's not because these diet plans are inherently unhealthy, it's more that there may be micronutrients that are of concern. So look through that list, and you'll kind of understand some of the factors that we may be having to address nutritionally. I've mentioned this term low birth weight infant, and I want to unpack that a little bit more so that you kind of understand it. So this is an infant born under 5.5 pounds, and as I said, this is one of the most significant risk factors that's going to predict long-term health. All right, and one of the there are many issues with this, and I'll just really kind of attack this one first. So that low birth weight infant is 40 times more likely to die within the first year of life than a normal weight baby. That's really significant. We see this in the U.S., and this factor is even more stark when we look at developing countries, where low birth weight infants are slightly more common than in the U.S. We also have very strenuous concerns for these infants that are low birth weight and premature. Okay, they may have suffered some kind of a growth failure or a nutritional assault in utero that's going to put them at much greater risk. So we want women to gain weight, and as I said, one of the greatest factors that we kind of look at with low birth weight is how much weight that woman gains during the pregnancy. Other consequences of low birth weight include reduced IQ and other kinds of cognitive impairments. So it may be something like an educational disadvantage, shorter stature. So these infants during their life cycle may not grow as well as other children. Although many low birth weight infants and premature infants do catch up with their peers by about the age of 2, there are other kinds of abnormalities that may persist. Now, low birth weight is really caused by a lot of different factors. Certainly the maternal environment, so that in utero exposure, but also it can be hereditary. So sometimes you see lower birth weight infants in a family. Also disease conditions, different kinds of exposure, so smoking, alcohol, those kinds of factors as well. And then there are some low birth weight infants that it's just kind of a spontaneous thing. And we really don't understand why that happens. So if you know someone that's had a low birth weight infant, it doesn't mean that they were not eating well or that they didn't take care of themselves. It's just that we know those are some risk factors for low birth weight infants. So we want to talk about that for sure. We also want to spend a few minutes talking about women who are obese at the time of conception and some of the risks that we see for these women. Now, it's entirely conceivable that these women have a very healthy pregnancy and a very, very healthy infant. But there are some things that are happening with this particular population that merit a little bit more discussion. So these women are more likely to require drugs to induce labor, so their body doesn't naturally go into labor as often. Also more surgical interventions. That can be forceps delivery, that can be different kinds of drugs required, greater risk of C-sections, things like this. They're also more likely to have some of the very common nutrition-related pregnancy complications. So there we look at gestational diabetes, hypertension, different kinds of abnormalities in the infant. So it could be a heart defect, for instance. And then these women, regardless of folate status, have a much higher risk of a neural tube defect. We're going to talk a little bit about what that is. I'm going to show you a picture of what a neural tube defect looks like. But one of the things we're doing now with nutrition for pregnancy is actually talking to obese women about folate much more than we were before. And so one of the commonly used approaches is actually to give women much higher doses of folate to try and overcome these neural tube defects, even though they're not related to folate status. So it's something they've had some success with, but it's a little bit tricky. So I want to take a look at some of the micronutrient needs during pregnancy. And you can see here on my graph that the green is going to represent a non-pregnant woman, and then we have in yellow pregnancy, and then the purple is someone who's breastfeeding or lactating. And you'll see that some of these increases are really, really quite high. So for instance, we have iodine and zinc, those are increased. When you look at something like calcium, this is often a shock to people that calcium needs do not increase during pregnancy or lactation. We're going to talk about that one. But my goal here for you really is to kind of recognize the importance of making sure that women who are pregnant or are likely to become pregnant or who are lactating make sure that they spend quite a bit of extra attention on their diet, making sure that they're really achieving those RDAs for pregnancy. Now, one way to do this, of course, is through a prenatal vitamin. And regardless of how great your diet is, a prenatal vitamin, especially fortified for the needs of a woman during pregnancy and lactation, there's no downside to taking this unless there's some kind of a disease state that you've discussed with your physician. We really, really want women to take these supplements because it's really important to make sure that there's no failure of those micronutrients and that we're doing well meeting those goals. Now, I want to spend a little time talking about some of our macronutrients. So carbohydrates, for instance. Pregnancy is not a time to be doing a low-carb diet. You have to have carbohydrates regardless of whether or not you're pregnant. And when we look at a pregnancy diet for someone regarding our carbohydrates, ideally about 175 grams a day. Okay? And kind of on the basement level, about 130 grams a day. 130 grams is generally considered the minimum even for a non-pregnant person. Sometimes you'll see this listed as 135 grams. That's a pretty small difference, so in that neighborhood. And then also fiber is important. That's important again for everyone. But one of the things that women often complain about is constipation and hemorrhoids and all kinds of bowel issues. So fiber and additional water can help to prevent some of those. And then protein. A woman who is pregnant needs on average 25 grams of protein more per day, above her normal calculated RDA. So we're going to use that figure we've kind of explored before, that 0.8 grams of protein per kilogram of body weight, and then we're going to add 25 to this. Now, for most women in the U.S., our diet is already containing plenty of protein, so a lot of people don't need to add more protein, but there are a subset of our population who may be consuming a lower protein diet, or if they're consuming maybe a lot of vegetables and the really high fiber diet, we need to have them shift a little bit and just examine the amount of protein in their diet. Now with fats, here's our third of the macronutrients. We really have a concern about these omega-3s, especially EPA and DHA. If you recall, these are found in things like fish, and there in the fish category, it doesn't have to be salmon, there are lots of choices. We can also find omega-3s, not EPA and DHA because those are only found in fish, but we can find other omega-3s in things like walnuts or flax seed oil. You can find it in eggs. So there are a lot of sources that are widely accepted by a lot of people regardless of their diet plan. These are important for brain function, and during that gestational cycle the fetus needs to have these in order to grow and develop normally. Then we can look at some of our micronutrients, and I've mentioned folate a few times, so I really want to start there because this is one that we have a lot of education out there about. And if you recall from our earlier conversations about folate, we looked at our fortification program in the US, and starting about the 1990s, we started fortifying our food supply with something called folic acid, which is kind of the laboratory version of this vitamin. Folate is the naturally found form of the vitamin. And what we're really looking at here is reducing our risk of neural tube defects. One of the things that happens early in the gestational cycle, in the growth of the fetus, is this neural tube is forming. This is basically your spinal column and all of those tissues of the central nervous system, including the brain. So you don't want to have, this folate in short supply during this time because you're going to see abnormalities in the development of this spinal column, this neural tube. So I just want to show you, let me bring up all these words, but we see very commonly two conditions associated with neural tube defects. One is called anencephaly, and what's happening here is that the fetus is born without a brain, or the brain has been severely compromised. You may see something similar to just a brain stem. This is terribly sad. You can Google pictures if you want to see what this looks like, but the shape and the size of the skull is dramatically reduced. And usually these infants might last 6 to 8 hours after birth. It's a terminal condition. There's no rectifying this. Spina bifida, which may be slightly more common in your everyday life and experience. You may know someone who's had a baby with spina bifida. I know in high school I had a friend who had this, and she actually had a surgical intervention, and she's just a fully grown, wonderful, healthy adult. So we can actually make repairs, and they can actually do in utero repairs of this spinal column and some of the tissues. Now I have a picture here, and this is the one from your book, and it kind of requires a little bit of narration to understand. So you can see there's kind of this, it almost looks like a little balloon, and this is this little bubble filled with spinal fluid, and it can also be filled with all kinds of tissues. It could be spinal tissue, nerve tissue, things like this. And it's terribly fragile. So you can imagine this can rupture or break. On ultrasound, very often this can be diagnosed, and if there's some kind of an abnormality detected, it'll be a C-section delivery. Now, in this picture, you can actually see what's happening. So here we have a cross-section, and you can see the bones here, the vertebrae, and that bubble is really well described here in this picture. And you can see that there's all kinds of tissues in there. And then here's one more version of that, taken from a different perspective. One of the things I just want to say about this is it can be corrected, but even with correction, you can see all different kinds of consequences. For some infants, it can be death. Some can't survive this kind of a deformation, or like my friend's child who's perfectly healthy. So it's on a continuum. I did have a friend that had spina bifida and he was wheelchair bound. So he didn't have the use of his legs and minimal use of his arms. So some of this may depend on where that deformation is in the spinal column and the severity of it as well. So now that we've kind of understood the folate story, I also want to turn to B12 because this one is somewhat related. When you think about B12, you should probably think about the myelin sheath on nerves, and it acts as an insulator. Okay, and one of the other things that you should keep in mind is that B12 is only found in animal products. So eggs or dairy or meat, something like this. It's not going to be found in beans or kale or some of these other kinds of foods. For vegans, people who aren't eating any animal products, they can get sufficient amounts from either a supplement, of course, or fortified foods. So with our vegans, they're our highest risk group. And you do see women who are pregnant and living a vegan lifestyle, so it's an opportunity for that conversation, okay? And when you think about folate fortification, if we take a step back, one of the concerns that emerged very early on was that when you have a lot of folate in the system, it can mask other deficiencies, and one of those is B12. So this is where a woman really needs to be very, very communicative with her physician and say, you know, this is my diet plan. Do you have concerns? You know, here's my diet log. Here's what I've been eating for the past 3 days. Are you concerned? Or I'm taking a prenatal vitamin with this amount of B12. Is that sufficient? So we really rely on the woman kind of communicating her dietary lifestyle to the physician or the midwife, either way, just so that we have more information and can respond appropriately. Before, I mentioned that calcium is one of those minerals that is not required in larger amounts during pregnancy, and that this is often very surprising. Now, one of the reasons that this happens is that you have greater absorption in the gut during pregnancy. You're also excreting a lot less of it. So you're increasing your absorption, decreasing the excretion. So you're going to have more available. Okay. The other thing is you really don't want a woman to be having a lot of calcium, especially in the later stages of pregnancy, because what will happen is that fetus becomes highly calcified. Okay, so all of those bones are a little bit less flexible. So if you just kind of think about the birth process, you really want that infant to be a little bit flexible, a little bit squishy as it's passing through the birth canal. It's going to make delivery a whole lot easier. So again, this is a conversation that a woman needs to have. If she doesn't drink milk, if she isn't getting enough calcium, that's a problem. It's not that her RDA is increased. It's that she may not be achieving the RDA from her diet. So, you know, here we're really, really looking for women to make sure they're getting that RDA. Magnesium is another mineral that's required for bone and tissue growth. And again, the RDA during pregnancy does not increase. But this is one of those minerals, and the reason I'm going to talk about it here, this is one of those minerals that is lost to food processing. And that's kind of surprising. Usually it's vitamins. So I'll just put that out there as a call for whole foods. When we look at iron, this can be a little bit tricky because we already know that women in general of childbearing age may have difficulty achieving the RDA for iron. And this really starts from the age of menarche up to menopause. Now, during pregnancy, one of the things that happens is that she no longer has a monthly cycle, so she doesn't have blood losses. Absorption of iron also goes up, so that's two really good things. Now, one of the kind of concerns is that fetus is going to draw very heavily on the mother's supply of iron. And what happens really, I mean, the problems that we see may not be with the first pregnancy with iron. Certainly we don't want a woman to be anemic. We want to make sure she's got enough in her diet and she's taking a prenatal vitamin that contains iron. But in the developing world, one of the things that we see happening around iron status is that maybe the woman has her first child in her teens when she maybe even has low iron status, and then gets pregnant with a second child without, you know, a good spacing there. So her body doesn't have time to recover. She becomes further depleted. Then the second, third, now we're on our third child. Third child comes around, fourth, and so on. And in some countries, and this is going to sound very mercenary, you can predict a woman's longevity based on when she has her first child and how many she has. So especially in places like Afghanistan and the Middle East and other countries where the diet is subpar or women's access to these different kinds of micronutrients is really restricted, we see women dying very often from anemia-related complications. This can surface during the pregnancy. It can be after because there is significant blood loss during birth. So kind of keep those in mind. It kind of gives you an idea of the importance of some of these minerals. Let's look at zinc. So iron and zinc are somewhat related. We know that they're both divalent metals and that they're really critically important for tissue growth and cell growth and development. When we see a woman who is deficient in zinc, you can really kind of predict low birth weight status of that infant. So those foods that are going to be providing iron for her, things like meat, also non-heme iron in things like leafy greens or in beans or other kinds of foods, we want to make sure she's got enough of those in her diet because they're going to not only give her iron but also the zinc. And absorption, and I just want to kind of bring this back into your frame of reference because I know we've talked about it. When a woman has a huge amount of one mineral in her diet, when we're looking at these divalent metals, so if she has a lot of iron, her zinc absorption may be decreased. So again, this is about balance in the diet. And those prenatal vitamins contain both zinc and iron as a result of this, so that we're trying to overcome any kind of a competition between these minerals. Now, I've talked about this prenatal vitamin quite a bit, and so I've included here a slide with, the different micronutrients in a prenatal vitamin, and there are a couple errors on here. So I'm curious if you can find them. We could pause here and I could let you think about it. But one thing I'm just going to bring up right here is iron. Okay, this 27 milligrams is actually 100% of the pregnancy RDA. So they've made an error there. And then also sometimes people will ask about vitamin A. And it says there that it's only 50%. Now this isn't an error in the label, but they'll say, well, why only 50%? Because when you look at some of these others, they're quite high. The reason is that we're very concerned about megadoses of vitamin A during pregnancy because it's teratogenic, which means that it can cause birth defects. And that's a super vocabulary word for you to be able to use. So mutagenic and teratogenic, you should probably know those. There are a couple of other things that I would be concerned about here as well. Okay? Like zinc, this is pretty high. But again, these are formulated especially for pregnancy. And so generally they're considered to be very safe. Supplements outside of this, outside of the prenatal vitamin, are to be incredibly well communicated to the physician. We don't want a woman really self-medicating with vitamins during pregnancy unless the physician is asked for that. Let's look at weight gain. And again, I mentioned that sometimes women will gain, 40, 50, 60 pounds, 100 pounds is not that unusual. You'll see women gaining a tremendous amount of weight. And we want women to be very, very careful about this. So we have a weight pattern that is considered appropriate. Okay? So about 3.5 pounds during the first trimester in total. Okay? Keep in mind that during that first trimester, she wasn't allowed any additional energy, no more calories. But we're expecting about 3.5 pounds of weight gain. So you're like, well, how does that work? Very often that when women are first pregnant, they don't feel as well, probably a little bit of nausea, things like that. So they're going to decrease their activity level. And what's growing here in these first 3 months is really all the structures of pregnancy. So, all of the tissues associated with the uterus, and then the placenta, umbilical cord, all of that. Then our weight gain from then on, after those first 3 months, is about 1 pound a week. Okay? And that's pretty easy to calculate. And we don't want her gaining more than that, but we know that she has to gain weight. And it's not just the fetus's growth and development, but it's also hers. Okay? And I have a picture here that I've found that's going to show you that there are some populations that actually should be gaining more or less. So someone who's underweight, anywhere from 28 to 40 pounds, healthy body weight, so this is someone that has an appropriate BMI at the time of conception, about 25 to 35. Okay, that's it, 25 to 35. And then overweight, she still needs to gain weight, but less, 15 to 25. And then someone who's obese, 15-pound minimum. Okay, we don't really want her gaining a whole lot more than that because it creates undue risks, but she still needs to gain weight. Now, one group that's not on here is multiples. So these are all related to a singleton birth, but if the woman is pregnant with twins or triplets or octuplets, certainly she's going to need to gain more weight than that. And then here we have where the weight is. So we can look at this slide and you can see where our average weight gain between 25 and 30 pounds, 35 pounds would be 30 pounds, and it's all divided compartmentally here. So muscles, all kinds of things, the placenta, the average size of the fetus. I just think that this is amazing. Okay, now that weight gain is a little bit different when we look at teenagers. Teenagers are in kind of this delicate position because, especially on the younger end of the teen years, if we see a pregnant 13 or 14-year-old, which certainly happens, even 12-year-olds, she is still growing a lot herself. And she needs to have enough nutrients for this fetus that's growing. So we need to be very careful that she eats for her own needs and then for the fetus. Okay? And if she doesn't, what tends to happen, and this happens to some extent anyway, is that a lot of teenage girls their own growth will cease. Okay, so if normally she was supposed to be 5'8", she may be 5'7" or 5'6", because this pregnancy is kind of out of sync with her normal growth pattern. So she needs to gain weight. If women are carrying twins, they need to also have more body weight. But we are very concerned about a sudden weight gain. So if someone puts on 6 or 8 pounds in a week, even 5 pounds, I would be a little bit concerned, because really we want her to gain a pound a week. So that represents a significant overage. And this may actually signal that there could be some kind of a problem, such as preeclampsia, which we'll also talk about. Now, I told you early on that pregnancy is not an illness. And we really want to get away from that mindset. We want women to be physically active, and there are so many reasons to do this. It's going to improve labor and delivery. If you think about labor, I mean, it is work. You're asking her to go through this Herculean task. The more physically fit you are, the shorter the labor, the less medications are often necessary. It does all kinds of wonderful things. And then think about this, if you've done some weight training, you're going to be able to carry around that infant a whole lot more easily. So we want women to be prepared not just for pregnancy and delivery, but also you're carrying around a stroller and all of these things that babies need. So, you've got a job to do and your body needs to respond. Also, it's going to help us manage very, very common nutrition concerns like gestational diabetes, and even a pregnancy that is highly desired is stressful. So this can be important for reducing psychological distress. Really, I think about it as distress and worry. From the time a woman finds out she's pregnant, and for the rest of her life, she's going to be a worrier. And so we can help to deal with some of those emotions through physical activity. Also, fewer discomforts during pregnancy. A lot of women will talk about sciatica, back pain, swollen ankles, all of these kinds of things. So we may be able to get some traction there. And then getting back to our pre-pregnancy body weight can be really helpful if we've learned a lot of good habits. Otherwise, it can be an awful lot of work, and especially if we've gained a tremendous amount of weight. I told you a few minutes ago that teenagers were kind of a special case, and that's true with weight gain, but then we also have some different kinds of concerns. So there are micronutrient concerns for teenagers, just like there are for any other pregnancy. But these are almost not more important, but I just want to highlight that they're a little bit different in some ways, because we don't see teenagers routinely getting enough of these micronutrients. So again, this is the importance of a prenatal vitamin. And then also having that shift from a teenage diet that may be rich in junk foods and soda and things that are not nutritive to one that is. And this can just be small changes. So, changing those snack foods from chips into carrot sticks and things like this. You really need to, when you're pregnant, think about your food as a budget and how you're going to spend those calories. And, there's a saying, you are what you eat. I don't want people to really be growing a fetus that's made out of Doritos and marshmallows and sodas. Really, those healthy foods that are going to nurture that little body are just critical. This can be very difficult in some ways, and we'll talk about some nutrition assistance programs that are going to allow women to do this if they're facing financial barriers or structural barriers such as transportation and access. Now again, a couple more comments about teens, because I think that although the teenage birth rate has gone down, and especially in Massachusetts, we've seen this in the past couple of years. Recently it was reported it's the lowest it's been in a decade. We're making great